Clients with seizure disorders can have a variety of different symptoms based upon the type of seizure disorder that they have. A seizure is a single event of an abnormal, sudden, or excessive uncontrolled electrical discharge of neurons, whereas epilepsy is considered a chronic disorder which is characterized by recurrent, unprovoked seizures followed by behavioral changes. Many times it's found that seizures are idiopathic, in other words, that they don't have a cause. About 2.5 million people in the United States have epilepsy, and it usually occurs in a younger population. In about 75% of all patients with epilepsy, they are under the age of 20. So your textbook has a great care plan that talks about seizure disorders and care of the patient that has a seizure disorder, so make sure that you take a look at that. Some risk factors for seizures include things that are listed on this particular slide. It can be many different things, such as an anoxic episode, could be related to a condition such as cerebral palsy, toxemia during pregnancy, congenital CNS types of defects, fever. A family history of seizures increases a patient's risk for seizures. Could be related to a hypoglycemic reaction or electrolyte imbalances. Other causes of seizures include head traumas, CNS infections, brain attacks or strokes, alcohol, drug abuse problems, metabolic problems, exposure to toxins, and many of the degenerative diseases can also have associated seizure problems. The case study for this particular lecture is going to be a 34-year-old female who had an emergency C-section after prolonged labor. During labor, she had sudden changes in her neural functioning and did develop seizures. And you are now the home health care nurse going in to do her home health care assessment postpartum 5 days after her delivery. So your assessment findings when you go in to check the patient include that the patient's pupils are perla at 3 millimeters, her hand grasps are equal and strong, her gait steady, she has equal strength in the upper and lower extremities, cranial nerves 1 through 12 are all intact, and in talking with the patient's family, they report that this particular patient has had no seizure activity noted. Just a little extra information, although the woman in our case study doesn't typically have what we define as epilepsy, this is a little bit of some information about women who do have epilepsy and are pregnant. They are at high risk for having babies that are born with congenital abnormalities. There's an incidence of about 2 to 3 times higher cases of babies that have problems with congenital abnormalities in those women who do have epilepsy. And some thoughts as to the reasons for that are that it could be due to side effects of the anticonvulsant meds that these patients need to take. Could also be related to some genetic factors. Could be also there's an increased risk if the mom does have seizure breakouts during the pregnancy, because during the seizures then there could be that risk of a lack of oxygen to the baby while the mom is seizing and those types of things. Some different classifications of seizures include partial seizures. Those are ones that only affect one hemisphere of the brain. The book sometimes breaks those down into simple partial and complex partial. And then there are also generalized seizures which affect all of the brain, and those are broken down into absence and tonic-clonic seizures. And we'll talk about some of these different seizures in some of the next few slides. Tonic-clonic seizures you may have also heard referred to as grand mal seizures. This is where you see the muscles get very rigid, there's jerking, the patient may look slightly cyanotic. Typically these seizures last between 2 and 5 minutes, where the patient has a loss of consciousness, and then after the seizure, which is called the post-ictal period, the patient's very sleepy, may not remember anything about having a seizure, may appear disoriented and that type of a thing. Many clients that have tonic-clonic seizures will have an aura before they actually will seize, and this is just where they have visual or visceral sensations that there's going to be something that's going to happen, and we'll talk a little bit about those in a little bit. Absence seizures are also known as petit mal seizures, where the patient may stare off into space. You may see lip smacking or eyelid fluttering going on during an absence seizure. If you talk to them, even though their eyes are open, they will not respond to you. Typically, absence seizures only last a few seconds. They don't have complete loss of consciousness, and the unfortunate thing with these is they can happen many times during the day. Until medication is given, sometimes people will have these happen up to hundreds of times during the day. Other types of seizures that fall into the category of partial seizures are simple partial. These are also known as focal or Jacksonian seizures. And the symptoms the patient has are going to depend on the site where it is in the brain. You may see some tonic movement of like the thumb, the hand, the face, or the foot, and sometimes these do end up in generalized seizures. One common cause of simple partial seizures are brain tumors. Complex partial seizures are a repetitive, non-purposeful activity such as lip smacking, aimless walking, that type of thing. The patient will have amnesia after that seizure. It may last several minutes to hours, and typically it originates in the temporal lobe, and the patient usually has an aura before they actually have this type of seizure. Phases of a seizure include these listed on the slide. Prodromal are the hours or days before the seizure. The patient may have a headache, they may feel depressed, they may just feel general malaise where they're just kind of not a lot of energy, that type of a thing. Pre-ictal phase is right before the seizure actually occurs, and the patient may receive an aura. This is actually a warning that the body is giving, saying that there's an imminent seizure about to happen. So depending on the area of seizure activity in the brain, the aura may change from patient to patient. A patient may have a strange smell or hear a strange noise or have visual changes, tingling or numbness. They may feel dizzy or weak, those types of things. And like I said, it's going to depend on the area of the excessive electrical activity in the brain as to what aura that patient experiences. What's really interesting is that there are societies out there that now train seizure assist dogs, which actually are able to pick up on these auras that patients have, and they can actually warn the patient that they are about to have a seizure. The ictal phase is the actual seizure itself, and that's going to depend on the signs and symptoms you see will depend on the type of seizure disorder that that particular patient has. After the seizure, patients typically are post-ictal, very groggy, maybe confused, maybe very sleepy and sleep for hours after the seizure occurs. The way that seizures are diagnosed are through CT, MRI scans, EEGs, lumbar punctures, and also labs are looked at to look at imbalances in the CBC, electrolytes, blood urea, glucose levels, those types of things. Patients with seizures are treated with anticonvulsant meds. Unfortunately, though, the meds will only control seizures in about 50 to 60% of all patients. And patients many times need to be put on multiple different categories of anticonvulsant meds in order to get their seizures under control. In about 35% of all patients, the seizures do not improve significantly with medication. And in practice over the years, I have very rarely seen patients sometimes put on a ketogenic diet, which is actually a very high protein, high fat, low carb diet in order to try to control seizure activity. And that's usually monitored by a nutritionist and a combination with the physician in order for that patient to be put on that type of a diet. And as I said, it's usually only used as a last resort if anticonvulsant meds are not successful with that patient. There are many, many different types of seizure meds that are on the market. One of the most common ones are the barbiturate categories, which is where phenobarbital falls into. And all of these different anticonvulsant meds have many side effects. And that can be a problem that sometimes patients have where they can't tolerate the meds. But phenobarb is known to cause anemia and different types of skin rashes. The benzodiazepines, such as Valium and Klonopin, are known to cause alopecia, which is hair loss, and also bone marrow failure. The hydantoins, such as dilantin, are known to cause gingival hyperplasia, ataxias, those types of things, different types of peripheral neuropathies, and they can also cause different blood dyscrasias. One thing with dilantin is that tube feeding should be held 2 hours before and after this particular med, because it can sometimes interfere where there won't be good absorption of the dilantin with a tube feeding. When we look at how we measure the effectiveness of the anticonvulsants, it's going to be two ways. One is we can get drug levels on these different drugs to look if they're in a therapeutic range. And the second way is we can just see if they're actually stopping the seizures or decreasing the seizure activity. Other anticonvulsant meds are listed here. Valproate, also known as Depakote, is another one, and it can cause hepatotoxicity, so you'd need to do liver profile studies periodically on these particular patients. Depakote can also cause nausea and vomiting and different types of nephritis problems, so we need to be checking BUN and creatinine. And then some miscellaneous anticonvulsant meds are Tegretol, which can cause leukopenia, dizziness, blurred vision, hepatitis, those types of things. And some new meds that are on the market, Lamictal is a new one, and also Trileptal, Topamax are some that are also listed there. Patients should be instructed to never stop meds abruptly. If they have side effects, the physician needs to wean the patient off of that medication. If they're stopped abruptly, it can lead to status epilepticus. And if the patient would miss 2 consecutive doses of their anticonvulsant meds, they should contact their physician for further orders what to do at that point. For patients that cannot tolerate medications or the meds just don't seem to get a handle on the seizure activity, the patient may be a candidate for surgery for this control of the seizures. What happens during the surgery is that there's an actual excision of the seizure area. They remove the focal area of the seizure activity. They do this through electrocortical mapping. Another option would be to have the patient have a vagal nerve stimulator implant. It's almost a similar type of an idea as a pacemaker, except that it's actually sending signals to a certain center in the brain to help control seizure activity. This can be implanted under the clavicle, and then what it does is goes to the vagus nerve in the cervical area and gives the brain electrical signals to control seizure activity. What if a client does have a grand mal seizure? With these particular patients, for example, in our case scenario, if you were the home health care nurse and the patient would have a seizure while you're there, you would want to stay with the client. If the client was not in a safe place, you would want to ease them to the floor, loosen their clothing, protect them from injury from any furniture or anything that might be in the near area that they might accidentally hit while they're having muscular jerking and that type of a thing. Keep the airway open, but you never want to put anything in the mouth. You don't want to restrain the patient or anything like that. Patients with seizure disorders should wear a medic alert bracelet. And if the seizure lasts longer than a minute, then the family should be instructed to call 911 for that patient. If the patient is placed on their side, that will help with secretions, or if they would happen to vomit during the seizure or anything like that. For the patient that has a seizure in a hospital or acute care setting, your interventions as a nurse would be to do the things also on the left, obviously not ease them to the floor if they're in their bed, but you'd want to make sure you have padded side rails, you have all seizure precautions in place. You'd want to time the seizure, observe details, the color of the patient, loss of consciousness, if the patient's incontinent, those types of things. The patient may need oxygen applied if they look a little bit dusky, or cyanotic around the lips. If that patient needs suctioned, you could do that, but you also do not want to restrain or put anything in the mouth of that patient. And you'd want to note how long the seizure lasted and the post-ictal behavior that that particular patient had. For the patient that has status epilepticus, this is characterized as repeated seizures without full recovery between each seizure. Typically, this will last about 30 minutes, or the patient will have repeated seizures, as it says. And the problem with status epilepticus is that it can lead to brain damage and death. Some causes of this are sudden withdrawal from anticonvulsant medications, infections, alcohol withdrawal, head trauma, cerebral edema, and metabolic disturbances. Care for the patient during status is going to be including the ABCs, obtaining IV access in order to give IV medications to stop the seizures quickly. Typically, Valium and Ativan are two common medications given for status, and these are given IV push. If the patient doesn't have IV access, they may go ahead and give diazepam rectal gel if there's not IV access. But typically, once the IV is in, they'll go ahead and get a loading dose of these meds, and then they can also be continued with further medication. In your speaker notes, it's given typical doses of these meds. Remember, if Dilantin is given IV push, it's very important to have that patient on a cardiac monitor because Dilantin can cause hypotension, heart blocks, and different types of cardiac arrhythmias. Also can cause CNS depression. You never want to give Dilantin IM or sub-Q. It can actually cause tissue necrosis, so make sure that you do have a patent IV before you give Dilantin. And Dilantin is not compatible with dextrose solutions, so you would want to use normal saline to flush before and after, or just hook up a separate line with normal saline in it. An NCLEX question for seizure disorders: which of the following observations would the nurse expect in the client after a tonic-clonic seizure? So if you answered A, then you are correct. Remember, those patients are typically very drowsy after the seizure. Patients with seizure disorders, typically we try to get them involved in support groups, and one example might be the Epilepsy Foundation of America. The next lecture is going to talk about clients with multiple sclerosis. And MS is actually an inflammatory degenerative autoimmune disorder of the neuromuscular system. And what it causes is patchy demyelinization of the CNS. And what happens is that the myelin sheath and the conduction pathway of the CNS are affected. And it's considered a chronic autoimmune disease from an environmental cause. It's a leading cause of neurological disability in patients 20 to 50 years old and has a peak age of about 30. And remember that myelin acts as an insulator and covers the axons in the nervous system. Myelin is important for nerve impulse control. So the patients that have problems with demyelinization have a separation of the myelin nerve sheath from the axon, and what this leads to then is that the nerve conduction actually slows down in these patients. So the latest thought is that there's perhaps a viral trigger with MS that leads to this problem that these patients have. This is a picture that demonstrates, if you look down at the bottom, a patient that has the demyelinization going on with MS. If you compare that to B, which is a normal nerve fiber with myelin covering it, you can see what a difference it would be, and then you can see why these patients would have the neuromuscular problems that they do. One hallmark assessment finding that you get with these patients is that they will have remissions and exacerbations of their symptoms. Initially, patients may recover during the initial, when they're first developing MS, but what happens over time is that plaque actually forms. The patient develops inflammation, edema, and scarring at the site, and this actually is what destroys then the myelin, and then that gets replaced by scar tissue, so you don't have that smooth transmission of the neural impulses. The myelin becomes progressively more damaged as the MS goes on, and this scar tissue then distorts the messages that get sent from the brain to the muscles, and that impairs bodily functions. So the end result is that patient has a a loss of functioning in the motor and sensory pathways. As said before, the etiology of MS is not quite known. It's thought perhaps that it's a viral trigger that actually stimulates an immune response, which causes myelin destruction. There also may be a genetic predisposition because patients have noted to have an HLA gene complex on chromosome number 6 in genetic studies that have been done. And also having a first-degree relative with MS increases your chances of developing it by 15 times. Environmentally, it's been noted that more patients with MS live in colder climates, particularly in the Northeast states, the Great Lakes areas, and the Pacific Northwest states, as well as Canada. So there's something to do with temperature changes there, and it probably overall affects about 350,000 people in the United States. There are many different types of MS. That's why you see some people severely affected with it, and some people only seem to be slightly affected. There's a type called benign. That's about 20% of all cases. They have very few exacerbations. They typically will be in remission most of the time. Relapsing, remitting, this is about 25% of all cases, and this is the most common one that's seen. And with this one, the symptoms will partially or completely resolve after an exacerbation. Some things that can actually trigger these exacerbations, we call them the aggravating factors, and those tend to be fatigue, stress, overexertion, temperature extremes, infection, things like that. Secondary progressive MS is about 40% of all cases, and this is where the symptoms worsen after each exacerbation. And with progressive relapsing, which is pretty rare, only about 15% of MS patients develop this particular type. But what happens here is it progresses to a permanent loss of function where the patient really has no distinct exacerbation or remission periods. So how do we diagnose MS? Typically the patients will exhibit 4 common symptoms: a neurogenic bladder, muscle spasticity, paresthesias, and also cerebellar ataxia. And there's some information in your book. You can look at your textbook to look for further information in this area. So symptoms that can be assessed for, the patient may come in with visual changes. They may say, that they've had blurry vision or double vision. They may feel that their visual acuity is just not the same as it was. The patient may come in with weakness or spasticity in the muscles where they have impaired motor function. The patient may notice that their gait has not been the same. They have intention tremors or speech problems or coordination issues. The patient may also come in with impaired sensations such as numbness and tingling in the extremities, and noting that they're having some bowel and bladder issues such as incontinence and neurogenic bladder. So patients may say they feel like they just have burning or crawling sensation in their legs and that type of a thing. The thing that makes MS tough to diagnose is that these patients' symptoms in the early phases can come and go. So the patient may have these symptoms and then they may just go away on their own. And the patient may not go to their physician until the 3rd or 4th time when these symptoms return. And they may say, I had these similar symptoms like a year ago and now they're back, and that's why I'm coming in to see you. So MS is actually diagnosed after other disorders have been ruled out. When that patient has 2 or more exacerbations lasting more than 24 hours within a 1-month remission period, or when it's noted on MRI and CT scan findings that the patient is noted to have 2 or more areas of demyelinization or plaque formation, and when that patient has a history of remission and exacerbations without complete recovery, and they have more severe symptoms that are lasting 6 months or so. So typically the patient will have a slow, steady progression of symptoms, which should set up a red flag to their healthcare provider. Unfortunately, there's not just a lab test that we can send patients for to check for this, but rather it's a conglomerate of different diagnostic tests that are done, such as a lumbar puncture, which will note an increase in the white blood cell count and also an increase in protein and lymphocyte counts. And also you may see an increase in the IgG in the LP counts. MR is probably one of the primary diagnostic tools because it can note the increase in white matter and also plaque formation in these patients. The CT may pick up on atrophy and white matter lesions. And PET, or position emission tomography scan, looks at brain activity and can note changes in glucose metabolism within the brain. EMGs will actually look at decreased nerve conduction in the muscles. And one thing that we talked about earlier, bring the patient into their optometrist or ophthalmologist for is that their initial symptoms may simply be that they have blurry vision. So goals of treatment include to keep the client as independent as possible for as long as possible, to treat the exacerbations when the patient has them, to try and slow and stop progression of the disease, and to give that patient drug therapy to reduce the frequency and severity of relapses. There are many different medications for MS, and they're listed here on this slide. Many different categories, and sometimes patients are put on multiple different meds in order to treat their exacerbations of their MS and to treat it from getting worse. So adrenocorticosteroids will help to decrease edema. They have, of course, the anti-inflammatory properties, and some examples would be ACTH, prednisone, and all the methylprednisolones. Muscle relaxants will help with the muscle spasticity issues that these patients have, and some examples of meds given here are baclofen and Valium. The immunomodulators help to prolong the time of onset to disability. An example of that would be the interferon medications. Immunosuppressant therapies such as Cytoxan and Imuran will also help to keep the patient from having as many exacerbations of their symptoms. And supportive therapies such as urocholine will help with bladder tone, Ditropan will help with bladder capacity, and Lorazepam or baclofen will help with muscle spasticity types of issues. There are many different experimental medications that are also out there. You can read about those in your textbook, but they're looking at growth hormone, chemomeds such as methotrexate, T-cell receptor peptides, monoclonal antibodies, and other antiviral or interferon meds to help with control of MS and those types of things. These would be some appropriate calls for nursing for our patients that have MS. For their sensory perceptual alterations and blurry vision, we may have to use alternating eye patches. We may have to make sure that patient is avoiding temperature extremes, because remember, that's one of the things that can trigger an exacerbation. Protecting their feet due to the neuropathies that they have, and inspecting skin daily. Tylenol and Tegretol will both help with all the neuro problems that they have as far as the sensory perceptual alterations, the tingling, numbness, crawling skin feelings, those types of things. And as you know, Tegretol is actually an anti-seizure medication, but one side effect of it is that it does help with neuropathic pain and that type of a thing. Physical mobility impairments are also going to be an issue for these patients, so they need to try to avoid fatigue and stress, space their activities out, and balance exercise and rest periods. That we will probably hook them up with occupational therapy and physical therapy for adaptive devices to help with ADLs, and make sure the patient knows about safety in the home issues, especially if they're starting to have gait disturbances and ataxia, even things such as rugs laying around that could trip them, things like that. And then remember, for the muscle spasticity issues, baclofen or Lorazepam is an excellent med for these patients. Another issue with that particular drug is that is not going to be tolerated for a patient that has lactulose intolerance, because that is a compound of that. And also that's a drug that shouldn't be used with patients that have liver or renal disorders also. These are some other appropriate calls for nursing. Body image disturbance. 75% of patients with MS will report fatigue so severe that they can't even do their ADLs. So we really want to maintain their independence as long as possible. Get speech therapy involved, try to have them continue their usual activities as long as they can, and support groups will be real helpful for these patients. Impaired swallowing is also an issue, so trying to get these patients hooked up with occupational therapy for adaptive devices and eating utensils is going to be helpful, and having the patient use a soft diet and a balanced diet that's low in fat but high in linoleic acid has been found to be helpful for patients with MS. These patients, as we mentioned, due to their musculoskeletal issues, are at high risk for injury. They're also at high risk due to all of the bladder disorder and dysfunction problems for urinary tract infections. So patients should be encouraged to increase fluids, be on a voiding schedule. They may eventually have to go to straight catheterizations every 4 to 6 hours if they have a lot of residual left with voiding. And the patients need to be taught things that can precipitate exacerbations. Lastly, patients, we talked about support groups being helpful. So National MS Society could hook the patient up with local support groups. There's also the National Institute of Neurological Disorders and Strokes, and these societies can hook the patients up with all sorts of services. It can get them equipment assistance, lending library, newsletters, those types of things. One treatment you may have heard about or read about also is on the experimental stages, but some patients with MS, if medications are not helping, sometimes will seek out alternative therapy, and one thing you may have read about is bee sting therapy, where patients actually will go to centers where they actually receive a multitude of bee stings. There's actually a compound in bee venom that's parallels, very similar to steroids, and some patients have actually found some success with this. Obviously, it's not FDA approved or anything like that, but some patients that are not getting a lot of relief from their symptoms from typical Western medication may start to look at alternative or complementary therapies such as this.